Assalamu alaikum, everybody. Welcome everyone on board. Um, we have started cardiovascular system, and yesterday we discussed some points about cardiac arrhythmias. Okay, so some of the points, if anyone wants to ask any question from our last discussion before some more people may join, any question from the discussion of arrhythmias? Okay. Today we will try to cover the topic of AICD and pacemakers. Okay. So, if, for example, if you come to know that you have a patient in which there is a permanent pacemaker implanted, okay. So, what do you think? What should you be thinking at that time? Who wants to take the lead? Anyone wants to answer?
So we have to see certain things in a patient with pacemaker.
Okay,
First of all,
like
related to the pacemaker. First of all, related to the pacemaker, we have to know what type of pacemaker it is.
just a second. Just a second.
When
Just a second. Just a second. It is better if you start even before that. Type of the pacemaker is important. Okay, fine. But there is something more important than that. What is that?
First of all, the patient factors like what was the indication for which the patient was inserted the pacemaker,
Okay.
the indication
Okay.
of pacemaker.
So that is most important thing for
Then
anesthetic
is the
because
patient pacemaker
either that
dependent or not?
indication, yes, no, that indication may be still there, or that indication patient is recovered from that thing and now patient is doing
Right.
fine or not. So this is because actually we are not cardiologist. Okay, so we have to extract our knowledge from that patient, that what is on our side. Okay.
Yes.
So just a second, please. Okay. So this is one thing. So usually, if we just stop here and few common indications for pacemaker.
So third degree AV block, symptomatic second degree AV block, even symptomatic sinus bradycardias, sick sinus syndrome, bifascicular trifascicular blocks, heart failure, cardiomyopathies,
Okay. Usually, if
and
you
sustained
again,
tachycardias.
I am trying to drag you towards anesthesia uh, mode. Okay. So usually the indication is usually because of some uh, congenital problem. Okay. In that condition, patient will have a pacemaker, or for any reason, usually there is damage to the conducting system of the heart because what may be the reason for the damage? Yes, this is the result.
MI.
This is the business, and that there is some
MI.
block.
There can be MI as a result of MI or a
Ischemic
dilated
injury.
heart.
Okay, it may be because of any reason related to ischemia or any related, for example, there is failure. Am I right? Usually, if you divide,
Yes, sir.
if you think logically, even if you are not going, because this trifascicular and hemi block and these are details which are usually related to the cardiologist. As if you, from
Yes.
your side, you will be quantifying it whether the patient is having some ischemia or patient is having failure, like you will be, and because your management will be depending on these things. Am I right?
Yes, sir.
So okay, fine, then there are fine details, as you were saying, that sick sinus syndrome or second degree AV block and etc. Details you can find everywhere. Okay.
Yeah.
Any other indication than these blocks in which you put the pacemaker or you need the pacing? Any condition
So
which
even
actually is not
tachyarrhythmias,
bradycardia?
sustained tachyarrhythmias,
What is that?
sustained VT.
Sustained VT. Okay, you are near because it's a named indication. It is actually torsades or long QT syndrome. Okay.
Yes, it's
Even
long
in,
QT indoors.
in that patients, you need to do the pacing. And even these patients need permanent pacemaker. Okay. So this is something other than the usual blocks which we all remember. Okay. Because that question was asked to me in the exam. So now I never forget it. This question was asked to me in EDA exam. Long QT syndrome and the things like that. And I ended up, okay. So now this is, we are just making a base of it. So this is the indication. So usually what are the sign symptoms for which, which will be there in this condition? It may be syncope, ischemic symptoms or things like that. Usually the commonest symptom which will need to the pacemaker is usually the syncope.
Syncope.
Okay. So syncope is the commonest of the symptom, which is the main indication. Okay. Usually. It can be any other thing, but usually you will be asking. So now you can ask the patient that whether you are off that symptom or no. Okay. For what, for which you were put that this pacemaker. Okay. So what other questions? Now, if you focus only on the history part, what other things you will be asking the patient only? Because actually, why I'm asking, stressing this question may be asked in the OSCE exam for different, some people who are preparing for the OSCE, because this question can be asked in a OSCE station as well, pacemaker, that a patient with implanted pacemaker, they can put a dummy patient and you need to ask the questions. Okay. So if we just focus on this part, that what will be the question? What other question you may ask? One of them is syncope or symptoms.
In symptoms of the patient, in history of the patient.
Yes.
Syncope, shortness of breath.
What else?
Fainting episodes.
Local pain. It may be pain. Okay.
Yes, sir. And then there are
patient might
bradycardia.
Yes, patient still may have the same symptoms like palpitation. Patient will not tell you bradycardia. Okay. Patient can tell you palpitation. Okay. So syncope, palpitation, these will be the thing. Local pain, these will be the thing. And what will be the signs? If you just look at the signs, what may be the signs in a patient with pacemaker you will be looking for?
Signs can be abnormalities in pulse, in rhythm, sorry, in rate and rhythm. And
if you start from examination, just focus, then we will go for ECG or anything, but just focus on the examination. What findings
in examination, of course, the rate and rhythm, first of all, in pulse. Okay. Blood pressure is going to be fine mostly.
Okay.
Then in heart, his heart sounds, we can.
You are missing a very simple thing. Again, because I'm just giving you a practice. Local
sound due to
on inspection on the patient.
Yes. You will find the local area. Maybe it is some swelling
yes.
or. Okay, so this is a finding.
Old scar marks of entry of pacemaker.
Because it is something being implanted inside. Okay, so you can find some local finding, local tenderness over there, and any signs of failure. It's a very simple answer, but when you are asked in the exam, very simple question, sometimes you are unable to pick it. So actually the same things which may be there in cardiovascular system, the same finding which we discussed when we started our system. If someone has missed that session, you can look into it. The usual symptoms and signs which we find in a patient with cardiac failure. Okay, so you can correlate those symptoms and signs here over as well. Okay, because they are all correlated, and you can have any of them. So now you come to, for example, ECG. Okay, so what will you find in ECG?
Sir, in history, we also have to inquire about some more things about the pacemaker.
Pacemaker, you are focusing on the pacemaker making and this thing. This is actually you will be consulting the. We will come on it. Okay, this will be related to the pacemaker because I have not touched that aspect up till now. That what is the type of the
Right.
pacemaker, what is the mode of the pacemaker, how to check it, battery. These are the things actually not related to the patient. Patient doesn't know anything about
Right.
it. He only
Yes,
needs
sir.
symptom, or his attendants know that the Baba falls down or no. Baba is moving nicely or no after the pacemaker. Okay. You can count it
In
here as well.
ECG, sir,
ECG, you will find the
right,
pacing mark.
basic
You will
spikes.
pacing spikes.
Yes,
Okay.
pacing spikes. There would be two P waves.
Mm-hmm.
No, two P wave, pacing spikes. Okay.
Pacing spikes you will be there. I'm not very expert on it actually. If anyone knows more about it, welcome. Okay, but
Yes, sir.
on the base there is the pacing spikes which come, and you can check the pacemaker dependency. Okay, you can
Yes.
this you can only do in a control setup. You can check the pacemaker dependency. Okay, you switch off the
If there are
pacemaker.
pacing spikes, yes, right.
Okay, so
Please
these are
go.
the things which you can do in the examination, and if you are doing the ECG. Okay, what else? Again, you will be looking at the baseline.
Chest X-ray, sir.
Now you come to chest X-ray. So what findings you can have in chest X-ray with a patient with pacemaker?
Number one, regarding the pacemaker, the site of the pacemaker, and some people can also see what type of pacemaker it is. Then the heart failure signs, of course, the cardiomegaly and pulmonary edema, pleural effusion, etc.
Okay, what else? You will find the leads. Okay, you can find the.
Yes, in this in recent exam, there was a station of pacemaker
Okay.
which I was asked, and there were two. Basically, there were pacing wires, and
Okay.
one wire was in atria, other was in ventricle. So the examiner asked me that, okay, what type of this? So I said it's a dual chamber.
Hmm.
So with the pacing wires, you can also tell this thing. It's a single chambered sensed or dual chambered.
Yes, you will use it. You will say it by that. Probably it is like that. Okay, because it's actually it's a probability. You are not 100% sure. For more accuracy, you can do echo. You can see the pacing leads in echo as well. If I'm not wrong, please correct me if I'm saying something wrong. I'm guessing it.
Yes, sir, but the X-ray was quite clear. There were two leads. One was attached, one wire was attached to the atria, other was ventricle. So I said it was dual and it was acceptable.
Yes. Okay, fine. This will be the question asked. Okay. So in X-ray, and you can again the same default thing. You can find you can have any abnormality related to the condition of the patient. It may be failure, increased cardiac shadow, signs of failure, aortic knuckle, whatever. You can say anything. Any finding can be there according to the scenario. Okay. So what else? Okay, now if now you are heading towards the other side of. So what other investigation? Now you have a patient with pacemaker, and you are going for preparing for any elective surgery. So what other investigation would you like to do?
So from the basics, we have to do a CBC to check the
CBC two,
hemoglobin level. If a patient
because you
to check
need in
the
a cardiac
mostly for
patient
the
more
hemoglobin level.
adequate hemoglobin. Okay, what
Cardiac
else?
patient, of course, we have to have a good HB. And
This
WBC
is
count
a
if there
this
is
is a
some sort
foreign
of
body.
infection or
Foreign body, so you a
yes,
patient might have some signs of inflammation or something like that. So this is also something you can defend, that you will be looking at the
yes,
WBC count, you will be looking at the platelet count. Such patients may be on antiplatelets or other medications. So platelet counts
yes.
you have to see. Okay. Then
Coagulation
what
profile,
else?
then
Coagulation profile.
coagulation
Okay.
profile,
Coagulation
Then
profile, how will you defend?
electrolytes. So coagulation profile, if the patient is taking any kind of anticoagulants like warfarin or
Okay, fine.
Taxane, etc.
Fair enough. Fair enough. Okay. Claxane, no.
Then elect
Claxane, no. Okay. In the exam, they are
yes,
very
heparin,
smart. They will catch you.
fractionated heparin.
How can you how can you monitor? Just give me a second, please. Sorry, I got just had to receive a call. Okay, where was I? I forgot.
So we were
Sir,
discussing
you
about
were
coagulation
asking
profile.
about how you monitor the Klaxin.
Yes. Okay. So Zishan, what is relationship
Sure.
between coagulation profile and Claxane? No, no relationship. Okay.
No,
If
no
you want,
relation. Yes,
That is why
it's
if
we
only
use
for
Klaxin
unfractionated
because there
heparin.
is
APTT can tell
yes,
us
because there is no
what
monitoring
concentration.
needed for Klaxin. For theoretical purpose, you can say 10 A levels.
factor 10A levels, but usually you cannot monitor it. Okay. Only in certain condition you will suspect the delayed effect. And what is that, Usman?
Delayed
Sorry,
effect of
like
Klaxin.
prolong effect in if you don't it is in renal failure. Okay, in renal failure you have to
Yes.
adjust the dose. Okay.
In that case, we measure the factor 10A level, sir.
Yes, you see, have you? I have never seen even in a specialized center someone doing platelet function assay. But you have to tell that if
Yes,
you have to
definitely,
monitor
yes, sir.
the platelet function, you have to do the platelet function assay in addition to clotting time, bleeding time. So this is only
So,
you can say the makeup of exam. Okay, the
yes,
beauty
we
makeup of
only in
exam.
practically, yes, in practically we just measure the bleeding time, BT,
Yes.
CTBT.
Yes, CTBT. Okay. So, okay, Zishan. So, what else? You told
Electrolytes,
electrolytes. Okay. So now, if you focus on electrolyte, what is why you want to do electrolytes? What is the problem with the
because
electrolytes?
these patients are prone to arrhythmias, so electrolytes should be in check.
There
Okay,
is
this
one
is
electrolyte which is very important related to pacemaker,
Action.
brain hall, MCQ, and no, it is potassium.
potassium.
Mhm.
Okay. Actually, the better answer will be that electrolyte imbalance will disturb the pacemaker threshold.
Yes.
Yes, sir. There is an MCQ regarding that. The patient was basically the anesthetists were hyperventilating the patient, and the pacemaker it doesn't function properly. So, what was the probable reason? So, the answer was basically he was doing hyperventilation, which leads to the metabolic alkalosis, which disturb the potassium level. So, basically the
Probably.
culprit was potassium.
Yes, so one most important is potassium, but of course calcium, magnesium, all can change the rhythm. So you can say, but at least you should be knowing that you know it, but it is the way how you explain it. That why you want to do electrolytes. Arrhythmias can be there in any patient without pacemaker. So you have to focus on the this pacemaker threshold. So now if some what other factors now okay now we will go in the intraoperatively we will discuss this thing. So okay, now you do the electrolyte. What else?
Other than that, chest X-ray and ECG, and if needed, echocardiogram can be done, or a stress
Mhm.
testing if needed.
Echo
And
you will be doing in which
opinion,
condition? Like if you see that the patient is still symptomatic and patient is still not getting effect of the pacemaker, then you can evaluate according to the patient condition, because this will be of course majority cases this will be a combo of hypertension, ischemic heart disease, diabetes. So according to the indication, you can have echo to see the systolic function, diastolic function, and things like that. Okay. So echo, ECG, chest X-ray, electrolytes. Anything else we are missing?
Yes, sir. Opinion of an electrophysiologist or the primary cardiologist of the patient.
Okay, well, we will enter that thing soon. Anything else other than that?
These are the
Mm,
main investigations needed, and then according to any comorbids or anything else the patient has, we can tailor our investigation list.
okay. Okay. So now if we just focus on intraoperative, I'm intentionally not coming to the chamber pace, chamber sense. We will do it because if we put our focus more on that thing, we forget the thing which is more important. That thing is actually the domain of cardiologist. Okay, we have to be more aware, even practically we have to be more aware by the practical aspects. So we will do that thing at the last. Okay, now you have a patient with pacemaker. You did everything, checked everything. Now intraoperatively, what are the things which you should be thinking, and what are the things which you will be avoiding, and what how will you conduct the anesthesia in this patient?
So an important thing is to consider the electromagnetic interference with the pacemaker.
Okay.
The most culprit in our operating rooms is the diathermy use, the cautery,
Okay.
for which we have to take certain measures like putting the, first of all, avoiding the
You are jumping.
monopolar and
I'm
using the
giving you a
bipolar.
hint. I'm stopping you. Go back. Go back. You are jumping to the surgical thing first. Even some things will be more
Mhm.
important than before that. You can tell a number of things. Would you like to arrange for the temporary pacing?
Yes, sir.
This is from your side.
Those are,
Okay.
of
Would
course,
you
the
like?
temporary pacing, and even some in some places it's written that electrophysiologist should also be present during
Of
the
course,
case.
like these are maybe it is it I'm going a little bit in a different style, or maybe I'm picking choosing, but I'm trying to tell you the which are more important things. Okay, you checked
Yes, sir.
electrolytes, everything. If step by step, for example, what monitoring would you like to do in this patient? Would you like to do some special monitoring in this patient, or you can defend
Sir, in
anything?
these patients, uh, we have to have standard one, standard two. We should. It's good to have a 12 lead ECG or at least V5, and then invasive monitoring,
Intraoperatively monitoring,
invasive
we
BP
see
monitoring.
not we don't say 12 lead, we see 5 lead.
I believe.
Okay, the full 5 lead ECG. This is one thing. Then you can have intra-arterial blood pressure monitoring if you are suspecting any hemodynamic sequelae. Okay, because this is very easy to defend. You can tell this thing. Also to do ABGs to see the monitor the electrolytes, acid base status. Okay. What else? In addition to standard one, standard two monitoring, you can defend like this. So monitoring is finished. Then what about would you like to do, because this aspect we will just tell in detail, but now only I'm just telling you one thing, that usually now the modern pacemaker, they have both defibrillator and pacing function. Okay, so to cover the pacing function, you will say that you will be arranging for temporary pacemaking. Okay, either transcutaneous or transvenous according to the situation. This is one thing. And the other thing, you will put the pacemaker in fixed mode. Previously they used to
Asynchronous.
say about magnet, but recent I have no idea. So because the things which I have never seen, or I never understand how what will be doing, but there was a concept of placing a magnet. Okay, but now it is
Yes, sir.
obsolete. Okay, this is one thing.
Yes, sir. It's
And for to
asynchronous mode which we have to put
yes,
it on.
just you have to make it fixed mode. Whatever you want to stabilize the patient, you will make it in the fixed mode. Okay, this is what
Yes,
is, because if normally it is variable according to the patient situation, and it is monitoring, it is doing its function. Okay, but in interoperatively, because there are so many things which will not be in your hand, So the concept is to make it fixed mode. This is one thing. For failure, you are covering it by temporary pacing. If this pacemaker has defibrillator function as well, so would you like to do something for that? You will switch off the defibrillator function and you will
Defibrillation.
put the
Yes.
defibrillator pads. This is the what they are
Yes.
asking, expecting you to answer or tell.
Yes.
Okay. Okay. And you should have the medication to support the heart rate as well, like atropine and isoprenaline and epinephrine in case the patient collapse. So you have to tell about the emergency medication and everything. Okay. So we cover this aspect, what you have to do. Surgical diathermy. Okay. Tell about surgical diathermy, relationship of surgical diathermy with the pacemaker.
It's preferred to use bipolar diathermy. First of all, we should ask the surgeon to absolutely avoid diathermy, but whenever it's needed, it's better to use bipolar. If he has to use unipolar or monopolar, what we say, we should put the earth pad very far away from the
It is not coming in the circuit.
from the
Which is not coming in the
pacemaker. Yes,
circuit.
sir. Not coming in the circuit. And the diathermy should also be used in short bursts, not
Short
very long
burst.
bursts.
Bipolar avoidance, bipolar short burst away. Okay.
Yes.
Okay. Anything else?
Mm,
Intraoperatively, would you like to tell anything else? We have covered a number of things. One important thing is that according to the monitoring, you have to manage the temperature. Okay. Because shivering will also have bad effect on pacemaker function. Okay. And now if you say something about medication, any medication would you like to avoid or something?
Sucks we can avoid due to the effect on potassium.
Succinylcholine. Uh,
Succinylcholine.
yes, succinylcholine mediated bradycardia, succinylcholine mediated electrolyte imbalance, succinylcholine mediated fasciculations. So all these things will be should be in your mind. Okay. And what else? Okay, so there are this is in the operation theater. Okay, so any other place if you have the same patient in MRI suite, so it is not indicated. Okay, you have to avoid MRI. You cannot do MRI with the pacemaker. Okay, and now because this is a specialized field, now there are in advanced countries there are some MRI in which they can use it, but I have just read somewhere that there are some MRI in which the pacemaker can also be used, but you should not say this thing. Okay. And what other procedures in which or other things related to anesthesia in which pacemaker will have some extra care, like lithotripsy? Okay. Lithotripsy is
Yes,
also
sir.
shock wave, so the pacemaker has a relationship with it. Is there any pain management thing which is also problematic with pacemaker?
Yes, sir. Our nerve stimulators are TENS.
TENS or this
TENS,
one
nerve stimulators.
acupuncture. Okay. So these are the things which you will be uh, thinking.
Acupuncture,
And
sir. How will acupuncture work?
acupuncture, I think it is the same because acupuncture also use the mechanism of TENS. Okay. Acupuncture is not the
But
only
there
the
is
pure.
no electrical stimulation in acupuncture.
There is. Okay.
In some
Actually,
of their methods.
yes, acupuncture does not only have the only pure needling, because you will be surprised. I have received it multiple times because of the backache which I suffer from, so I know about it. Okay, so I think we have covered almost everything which is more important for anesthetist. Okay, same care, maybe you can shift the patient to post-operative care. Okay, and post-operative monitoring, it is better to keep the patient monitored. And now the things which were from where you were starting and I drag you from there. Okay, now you can tell about those things. what are the thing which are about there is another thing which I forgot, is radio frequency ablation. Okay.
Yes.
Electroconvulsive therapy. You see, now I have opened the article so I can show you these things. I will just show you at that, because actually these are the things which are now left are crap things. Actually, it is not related to us, but we have to know about it. Okay.
ECT is related to us. We do.
No. I'm not talking about ECT. I'm talking about the nomenclature. I hate it.
Yes.
I hate it, because when I used to study,
Yes.
nobody told me that what are the more important things. So that's why I only used to cram those things which I have not even discussed up till now. Okay. Because people, when they start the pacemaker topic, they are drowned in this part. Okay. Which is actually not that much important for anesthetist. Okay. So we started from here, that these are the things you can have: chamber pace, chamber sense, mode of response to sensing, programmability, rate modulation. Okay. Multi-site pacing. And similarly, you will be labeling accordingly. It may be none or it may be dual. Okay. Dual pace, dual sensed. Okay. Because choice of pacing mode, it is not your job. Okay. If they are asking
Yes.
you, it's actually, I don't know if anyone can want to speak about it. If anyone has experience, he can speak out. Okay. It's written here actually. If you want to see, this is I will share the link of the articles related to pacemaker in the video upload. Okay. So you can have a look on it. Usually now these days, this is AICD. Okay. So AICD, they have a little different nomenclature. Okay. So because I don't think so they should be asking you in the anesthesia exam. So frankly speaking, I have nothing to say about it. This is in front of you. You can have a look. Okay. And another thing, yes, you can be knowing about something about electrophysiological study. Okay. Because these days, in addition to using this pacemakers, now it is available in Pakistan as well. No, not everywhere, but in some major cities, that they are finding the area of the culprit area for the generation of the arrhythmia, and they ablate it. Okay. So the things which we intentionally missed is that what type of device and what mode functioning properly, how dependent. Okay. And electromagnetic interference, what is the risk? So these are the things which definitely you will ask to have the checkup. And from your side, you will be ready for the things. Okay. Any question about it? Any question, please, before we finish? Radiation therapy and okay. So if no question, we will stop here. Okay. I hope you get some benefit. People who are going for EDA IC, this question may be asked to you in a similar fashion. Okay. But of course, actually, because I have to cover a number of people of different uh, interest at the moment. Okay. Dr. Sumera, I will share, but actually this link I share every day. Okay. And you can find all the articles anytime. All of you are welcome to ask any question anytime. Someone was asking about the recording, so you will get the recording, all the discussions I have put on YouTube, and you can follow it over there. I have made the playlists, and you can approach from there. Okay. So thanks a lot, everyone, for your presence. We will do some topic next time. Assalamu alaikum.